Okay, so doing pancreas today. You said you got your notes with you?
Yes.
Okay, perfect. So first thing I wanted to do is just go over, like I did when I went over the renal system with you guys last time, was go over some of the anatomy and then some of the functions. Because once you know the functions, it makes more sense because whenever the pancreas is in distress or not working, the functions don't work. So if you understand the functions, you can understand like what the signs and symptoms would look like. Okay. So the pancreas is located, do you remember right or left side?
Is it left?
Yeah, good job on the left side. It's not a trick question. So I don't know if you can see this at all. It's kind of, I wanted to draw a little diagram. So this is not the best drawing, obviously, but this is your sternum. These are the ribs. Over here, this one is the liver. So that's more on the right side. And then your stomach is over here, and then your spleen is over here. And then I drew the pancreas in blue so that you could differentiate it from the others, but also because it's in the back, right? So the stomach and the spleen are in front, and the pancreas is behind the two of those structures. And it's mostly on the left side. It does kind of cross over a little bit, but the majority of the pancreas is on the left side. Okay. So that's just a quick little diagram. I want to pull up, let's see if I can, well, I don't know if you can, are you on your phone?
Yeah.
Okay, let's see if this will work. I had an image pulled up on my computer that I can screen share. So let's see if you can't see it, just let me know.
Okay.
Screen share. Okay. Can you see this picture?
Yes.
Perfect. Okay, so you can see this is a diagram of the pancreas. And you can see on the green structure is the gallbladder, and it has like a little duct that goes all the way down through the yellow pancreas and connects into the duodenum, which is the pink. Do you see all of that?
Yes.
Okay, so the reason why I want to show this picture is because it helps kind of understand like how some of the causes can happen for like pancreatitis and things like that, which we'll be starting with is pancreatitis. So some of the causes here, you can see like if you ever heard of gallstones. Have you guys gone over that at all?
Not yet.
Okay, well, your gallbladder, can create gallstones, especially if someone has like a high fatty diet or just like a bad diet in general. And the gallstones are kind of like kidney stones. Like the same way that the kidney produces kidney stones, the gallbladder can produce stones. And if they get stuck down the common bile duct, you can see where the common bile duct intersects the duodenum, and also there's like a yellow branch, the pancreatic duct coming off of the bile duct. Do you see that? So imagine if a gallstone got wedged, like right at the opening of the duodenum, where before the intersection of the pancreatic duct and the gallbladder, then all of the enzymes that would be in the pancreas would also be stuck, right? If there was a blockage at the opening, there would be no way for pancreatic enzymes to exit out of the pancreatic duct into the duodenum. Does that make sense?
Yes.
So, like, a stone blocking both of them. So that would be one of the potential causes of pancreatic or pancreatitis, is if there's a gallstone blocking it, right? Because one of the functions of the pancreas is to produce enzymes. And some of those enzymes, they're to help with digestion. So they help with absorbing carbs, fats, and proteins. Okay. So the three different enzymes are amylase, lipase, and trypsin. Do you have that on your notes?
No, I don't have that.
Okay. I didn't know if you guys had finished talking about pancreas yet. I think you had started it, but we're finishing it tomorrow.
We haven't started. We're still covering liver.
Okay.
Almost done.
I think one of the other students said that they were going to be finishing pancreas tomorrow. So this will kind of at least give you a head start, so that when you go to class, that it'll make more sense because you kind of already heard some of it. Okay.
Okay.
So yeah, so one of the functions of the pancreas is that it produces digestive enzymes to help you when you eat your food, help digest it, to absorb those nutrients into your body. Okay, so whenever you eat, depending on, if it's really fatty or if it's really sugary or whatever, the pancreas will respond by producing the amount of enzymes that's needed to break it down. Okay, so the three enzymes again are amylase, lipase, and trypsin. The amylase is what breaks down carbohydrates. So amylase does carbs. Then there's lipase, Lipase, and that sounds like lipids, right? Lipase lipids, so that breaks down fats. And then the last one is trypsin, which is Trypsin, and that one breaks down proteins. Okay, so whenever you eat, the presence of food, when it passes from the stomach to the duodenum, you have your stomach, and then the first thing that it goes to as it exits the stomach is the duodenum, right? As the presence of food enters in the duodenum, the pancreas picks up on that presence of food through that the entrance there where the duodenum goes into the common bile duct and the pancreatic duct. The pancreas senses the presence of food and starts producing those enzymes. So let's say that you are eating a bunch of food and your gallbladder has a bunch of gallstones, and a gallstone is wedged at the junction of the common bile duct and the pancreatic duct so that the pancreas is producing the enzymes, but it can't get out. All right, so the enzymes come out from the pancreatic duct and go into the duodenum to help digest that food. Does that make sense?
Yeah.
So when there's a blockage, the enzymes can't escape, so they're just sitting in the pancreas, right? And why this is a problem is that the pancreas will start to literally digest itself with all those digestive enzymes sitting in there, right? And that can be very, very painful, as I'm sure you can imagine. So that is one potential cause of pancreatitis. And I just wanted to mention that now as you see the picture, because it makes more sense when you can see like the ducts and how they line up. You'd be like, oh yeah, a stone here would block it, and make more sense that way. So that's, again, one of the functions. Some of the other functions of the pancreas are producing glucagon and insulin. So I think they'll mention in class that the pancreas, deals with a lot of hormones. It produces endogenous hormones and exocrine hormones. So the exocrine system is the digestive aspect. So like the amylase, trypsin, and the lipase, that's all part of the exocrine system. The endocrine system, when you think of endocrine, you think of like hormonal things like that. So it's like that's like the insulin and glucagon aspect.
I see it now. It's the next page. I see the lab evaluation. Yes.
Perfect. Okay, so there's two different cells part of the endocrine system. You've got the alpha cells and the beta cells. Okay, so the alpha cells are what release the glucagon. And do you remember what glucagon does, or do you want a refresher of that?
Can you refresh me? I'd rather learn like I don't know anything.
No, yeah, perfect. Especially because people watching this video might need a refresher too. So the pancreas is the main organ in charge of regulating your blood sugar levels, right? So first thing you think of is like diabetics, right? So diabetics and pancreas, it's all very important. So the alpha cells produce glucagon. What glucagon does is it's a hormone that is released when your blood sugar levels are low, right? This could be from fasting, right? As people do fasting, intermittent fasting, your glucose levels can drop, or it can be from like intense exercise and you just like burn up all of the calories that you have stored up. So what this does is like you don't want to have your blood sugar drop too low, right? Because that can be dangerous. You can go into a coma or have symptoms of hypoglycemia, right? So in order to prevent that, glucagon will be released when your blood sugar levels are low. And what it does is the glucagon travels to the liver, and the liver is kind of like a pantry for glucose. So like you store what you're not using there. So like when you're cooking, you might go to the pantry and get some sugar out of a big bag and use what you need for like if you're baking cookies, you use that sugar. And like that might be what's in your bloodstream at the moment, right? But the rest of the sugar that you're not using, that you're storing for later, is stored in the liver, and they call that glycogen. So glucose is when it's like floating in your bloodstream being actively used, and the glycogen is stored sugar in the liver. Does that make sense?
Yeah.
So let's say you're baking your cookies and you realize, oh man, I didn't have enough sugar, I need to get more. Glucagon would be the one that goes to the liver and gets more sugar out of the reserves. Does that make sense?
Yeah.
So that's the function of of glucagon. And how I remember that is glucagon literally like sounds like glucose is almost gone. Right? So glucose is
Yeah.
almost gone, meaning it's really low. So it goes and gets more. So glucagon, the purpose of it is to raise your blood sugar. Does that make sense?
Yeah.
Okay, so then the opposite of that is insulin, and insulin is produced by the beta cells. So you have the alpha cells do glucagon, and you have the beta cells do insulin. Insulin does the exact opposite. When your blood sugar levels are getting too high, the insulin comes and drives, some of that sugar out of the bloodstream, puts into the cells. All right, so and that's the two opposing forces that help regulate and keep your blood sugar levels stable. Does that make sense? Do you have a question? Oh, I think she's frozen. Are you there? Okay, so as I was saying, the alpha cells produce the glucagon, right? And the beta cells produce the insulin. And the insulin works the exact opposite from the glucagon. So when your glucose levels are too high, right? We don't want glucose levels to be too high. We don't want a blood sugar of 200, right? The insulin is going to be released from the pancreas. The beta cells are going to be like, okay, time to secrete some insulin. And what the insulin does is the insulin acts as the key to unlock the glucose portal in the cell to allow glucose to exit the bloodstream and go into the cell, because that's where we want the sugar to go, is into the cells, so that the cells can use it for energy and whatnot. So like if this is like your cell right here, this circle here, the glucose in your bloodstream can't enter into the cell without insulin to unlock the door, right? So insulin will latch onto the cell, it'll open the door, which allows the glucose to rush in, right? So those are the two hormones, glucagon and insulin, that work together to regulate your blood sugar and keep it at a happy level. Does that make sense? So blood sugar is too high, insulin secreted to get some of that sugar out of the bloodstream and put it into the cells. The glucose levels are too low, the alpha cells are going to secrete glucagon to go get some extra glucose from the liver. Does that make sense?
Yeah.
Do you have any question on that?
So now it's like when that is impaired, it's doing the opposite for both.
Well, it's not that it does the opposite. It's just that when it's impaired, the body is just, the pancreas is no longer able to secrete these things. Just like with like when we talked about renal, with like kidney disease, chronic kidney disease, it's like the kidneys just start losing their ability to function, right? So like one of the things that the kidney made was bicarb, right? And so when the kidney is like impaired, it just isn't able to produce bicarb anymore, right? So like when the pancreas is impaired, it's just no longer able to produce insulin, right? So this is interesting because sometimes you'll have someone who has pancreatitis and the pancreas isn't able to produce what it's supposed to, and it will look a lot like diabetes, because the person will have all the symptoms of like blood sugars being crazy, and you think, oh, this person's a diabetic, when really it's just that their pancreas is being whacked out, right? So if you fix the acute pancreatitis, it'll be fixed and they'll go back to being healthy. Does that make sense?
Makes sense.
Okay, so let's keep going. So we went over the functions. So the functions are producing digestive enzymes, amylase, lipase, and trypsin, and that's the exocrine portion of the pancreas. Then the endocrine portion was the alpha cells with the glucagon and the beta cells with the insulin. Okay, so let's move on to pancreatitis. Like I said, there's some different causes. You can have the gallstones, like I showed you in the diagram. Another thing, you could have a tumor, right? So like, let's say you have a tumor that's kind of doing the same thing as the gallstones, that are like pinching off It's the tumor is growing so big that it's pinching off the ducts, right? So it's like collapsing it, just like a gallstone would be blocking it, like the tumor could be pinching it off. Does that make sense? So the enzymes aren't able to come out the same way. Okay. Other causes, I mean, alcohol is like your number one thing for pancreatitis. Alcohol is really damaging to the pancreas. So people tend to assume that if someone's in the hospital with chronic pancreatitis or whatever, that they're an alcoholic, but you can't always assume that, because there are other causes, like I said, gallstones, tumors, even some autoimmune things that are going on. So different things like that. So let's talk about some signs and symptoms of pancreatitis, and we'll look at them and kind of like logic our way through them so we can understand rather than just memorize. Okay, so first signs and symptoms I've got for pancreatitis is severe GI pain, and that makes sense, right? Because like I said, that the pancreas is like starting to digest itself with all those enzymes backing up and can't come out. Does that make sense? The pain will be worse when laying supine, like laying on your back, belly up. Other things like nausea and vomiting will be common, which, makes sense because it has to do with digestion and all of that. You could have some abdominal distension, your belly's swelling. And so far, all of these are kind of like non-specific. Like anytime you have GI issues, you're going to have like pain, not nausea, vomiting, right? So these don't exactly clue you in that it's specifically pancreatitis, but these are signs you will see nonetheless. There are a couple some signs and symptoms that are specific to pancreatitis. So if you have a patient come in, they've got nausea, vomiting, abdominal pain, whatever, you're just like, okay, well, that could be any number of GI problems, right? You've got a stomach, you've got a liver, you've got, a colon. You don't really know what's the cause, but if they have there's two symptoms that are very specific to pancreatitis that should make you be like, okay, I know what this is. And those two are called Gray-Turner's sign and Cullen's sign. So Gray-Turner's is where you start to have bruising on your left flank. So your flank is like right here on your side, right on like, in this area right here, which makes sense because your left side is where your pancreas is, right? So, and the reason why you'll see some bruising is because when you're, all these digestive enzymes that are accumulating the pancreas can start to eat through the pancreas, right? And so it can cause bleeding, right? Which is very painful. So you'll start to see some bruising there, which is indicative of like some bleeding from that pancreas. Another place you could possibly see bruising is around the belly button or the umbilicus, and that one is called Cullen's sign. So the way I remember the difference between Cullen's sign and Gray-Turner sign, because they're both just bruising and bleeding, is that I think, okay, when you roll over and turn over, you're going to be laying on your side. So Gray-Turner's is on your side.
Okay.
So with me so far?
Yes, I was trying to find a different one because I wasn't feeling yours, so I was trying to come with a different one for me to remember.
Yeah, whatever works for you. I share whatever works for me, and sometimes it helps people, sometimes it doesn't, but whatever you can think of. Any little memory helper can really make a difference.
Yes, that's true.
Another sign and symptom of pancreatitis would be hyperglycemia, right? Can you figure out why that would be?
Well, because you talked about the insulin being affected.
Right. So if the pancreas isn't able to produce insulin, you're obviously like still consuming calories, right? You're still eating. So your blood sugar is just going to continue to rise and their pancreas isn't able to produce insulin. So your blood sugar is just going to be high and you might think, oh, this person's a diabetic. And it's like, no, this person's just having pancreatitis, right? So hyperglycemia is a sign and symptom. Another kind of interesting one that you might not like have thought is that some more signs and symptoms would be some pulmonary complications like respiratory. And the reason why is because those digestive enzymes, as they're continuing to like eat through the pancreas and like your abdominal area, is that they can seep into the thoracic cavity. They can seep into the lungs, they can travel through the lymph and get to the lungs. And so you can start having like different respiratory issues. because of those digestive enzymes. So you wouldn't think that like respiratory has anything to do with pancreas, but it's because of those enzymes just eating through once it gets bad. Let's see what else. Some other things, peritonitis, just the rigid, hard abdomen, and that's, the abdomen responding because of the irritation of those enzymes filling the cavity. It's just like starting to get inflamed and irritated. And then paralytic ileus, where just your intestines kind of freeze and stop passing stool through. Same reason, they're just kind of getting irritated from all of those digestive enzymes in the area.
I see it. Paralytic due to peritoneal irritation.
Yeah, like those digestive enzymes are some serious business, right? And they're just highly irritating if they're not where they're supposed to be. Clear on that?
Yes. Thank you.
So the pain, like I said, you're going to have pain in your GI, but specifically it's going to be on your left side because that's where the pancreas is. Also, you might feel some pain radiating up to your left shoulder. Some pain is interesting like that, like it radiates to different parts of your body. So left shoulder pain is also sometimes common. You might see someone have a low-grade fever, and that's again just because your immune system is responding to like this potential irritant. So yeah. What else? The other one, the other sign and symptom that you might see, this one is hypocalcemia, so low calcium levels. And I did some research to try and figure out like what it is about pancreatitis that causes there to be low levels of calcium. And there wasn't like a general consensus about why it causes that. From the research that I was looking up, it was like the exact cause of this is unknown. So I can't really give you an answer as to why that happens, but it is one of the hallmark signs of pancreatitis, and it's generally a bad sign. So if someone has hypocalcemia, it's usually kind of like a bad omen, kind of like, okay, well, if they have this, it doesn't have a very good prognosis, if that makes sense. So
Okay.
yeah, so the worse that their calcium levels are, the worse kind of their prognosis is for the severity of their illness. Okay.
I put it under electrolyte imbalance because I didn't see anything like hypocalcemia.
It's under potential complications. I don't know if, because I have the notes printed out, but these are from a couple years ago, so I don't know if she's kind of rearranged the material. But it's all the same info.
Okay. No, I don't see hypocalcemia. I just see electrolyte imbalance. I see hypovolemia
Yeah.
and hypovolemic shock. And yeah, I'm not, maybe it's in the pages to come, but as for now, I'm not seeing it.
Okay, well, you can find it in your notes later, but I know that that's like, it's especially under like diagnostic tests, you can see it under calcium being low as well.
Oh, I see CMT she has calcium underneath.
Yeah, so calcium will be low.
All right, thank you.
Let's see what else. I think that's that for signs and symptoms, most of them, unless you have a specific question that I missed. Oh, here's one. How do you know, like, what are some signs and symptoms of a person having low calcium? Besides, like, just doing a blood draw, what symptoms can you see on a person?
The trousers and the Chekhovec thing.
Yeah, so I don't know how to pronounce it either. Chvostek's sign. I remember that one's the cheek because they both start with a CH. You tap and it like, makes their mouth twitch, and then the trousseaux or trouser, whatever, the blood pressure cuff making their arm come in. So those are some calcium imbalance signs. All right, let's look at some diagnostics that you can do. Diagnostic tests. So let's see. If you're going to do a diagnostic test, you can look at their amylase levels and lipase levels. So they're going to actually be elevated. And you might think, oh, well, if the pancreas isn't like working, it shouldn't be producing. It's like, well, remember many of the reasons why the pancreatitis happens in the first place is because the the exit is blocked, and so that the enzymes are building up, right? So you're going to have a lot of them just kind of building up. So your amylase levels and your lipase levels are going to be elevated, which is why it's causing all of that digestive irritation, right?
It makes sense. So now the complications like the paralytic ileus and everything, it's because those enzymes are still remaining because they can't exit due to like a tumor, or you said it could be just like any obstruction. Okay. Correct me if I'm wrong, please.
No, you're good. You're on the right track.
Okay.
So that's why those enzyme levels are going to be increased, because you're just, that's what's causing the irritation. But the irritation is going to be damaging to the pancreas, so the pancreas isn't going to be able to produce things like insulin. So does that make sense? So the amylase levels, lipase levels will be high. Your white blood count, do you think your white blood cells are going to be high or low?
I think it'll be high.
Yep, because they're responding to like a potential threat, so they're like, oh man, like they're treating the digestive enzymes kind of like as a foreign invader, and so they're gearing themselves up to fight back. What about your H&H? What do you think that's going to go up or down?
Wouldn't it go down?
Especially if it's causing bleeding. Like I said, like the bleeding can cause that gray Turner's and Cullen sign with the bruising. So it can cause some internal bleeding. And if it does that, your H&H will go down. So H&H will be down. Glucose, up or down?
Up.
Right, because no insulin, right? So that's all that. So that's a part of the, and then they talk about here, there's like a Ranson's criteria. Do you see that in your notes?
Ranson?
It's just like it's like a criteria. They call it the Ranson's criteria. So if you meet a certain check boxes.
The survival rate.
Right.
Sorry, I know we're still on like lung, like we haven't even done lung cancer. So like I have to flip through my notes to know.
No, you're totally good.
It's like, okay.
This is just to help get you ready for tomorrow.
Yes, and I'm grateful. Ransom criteria, yes, says measure severity and mortality.
Right. So like the more check boxes you have, like it's worse, right? So like hypocalcemia, for example, is one of those check boxes. Like, okay, if you have hypocalcemia, that goes towards predicting mortality. So that would be bad, right? Like you don't want to have hypocalcemia. So it's just they look at the different signs and symptoms that you have, and like the more bad markers you have, then it's just the less likely you have of survival. So I don't think you have to memorize like any specific things. They just want you to know that like the Ranson's criteria is what predicts mortality. Okay. All right. So interventions. Let's talk about like, okay, what do you do with this patient that is having pancreatitis, right? So the number one thing definitely you want to help with is pain, right? Because this hurts a lot. So like pain medicine is going to be a big part of it, and you're not going to be like, oh, here's some ibuprofen, right? Like, no, we're bringing out like the big guns. They're getting Dilaudid, they're getting morphine, because this is extremely painful. Okay, because just imagine like you being eaten alive from the inside. That's not a fun time. So definitely pain management. Calcium replacement is a big one, right? Because you have that hypocalcemia, and that can, that has muscular problems, but calcium is also important for heart, right? So it can cause some heart problems, heart dysrhythmias, things like that. So we want to make sure their calcium is good. So checking their electrolytes. What else? Fluids, making sure they're on good fluids, fluid replacement, especially if they're having hypovolemia, right? And if they're bleeding a lot internally, that can make their blood pressure go down. That can cause hypovolemia if there's significant bleeding. So fluid replacement is pretty much always going to be an intervention for most everything. What else? Glucose checks. And this is something that is confusing to patients, right? Especially if they don't have any idea about much medical knowledge. They'll be like, nurse, why are you checking my blood sugar? I'm not a diabetic, right? So this is an opportunity for patient education to explain to them, like, you know, your pancreas is what produces the insulin, and right now your pancreas is in crisis, right? And it's not able to do its job while it's in distress. So it's not able to produce the insulin right now. And, you know, make sure that you're not like making them feel stigmatized that you think they're diabetic. And it's like, no, I'm healthy. I'm not a diabetic. You know, and explaining to them like we have to check your blood sugar levels just to make sure how much insulin we need to give you because your pancreas isn't able to make it right now. Does that make sense? Yeah. So I've seen that happen a lot of times where patients just are like, they refuse the glucose checks because they're like, oh, well, I'm not diabetic. So the other thing you can give them is some antihistamines or some anticholinergics drugs. And you're like, okay, why? What does that have to do with anything? Well, one of like the side functions of antihistamines and anticholinergics is that they actually prevent enzyme release from the pancreas. So it'll help reduce the amount of enzymes that are being produced by that pancreas to kind of slow down like the amount of enzymes that are being released. Because if it's still blocked and the enzymes can't get out, you don't want it to keep producing more and more. You want to kind of slow it down. So something else you can do is make this patient MPO, right? The reason why is because the pancreas produces these enzymes in response to sensing food, right? So if there's no food, the pancreas is going to stop producing those enzymes. Does that make sense?
Okay.
So keeping them MPO for a while until, it kind of calms down. If they're going to be NPO for a long time, then they might get like an NG tube or something that will, or like not an NG tube, but like have you heard of like the J tubes, like they go down through the stomach but keep going, they don't stop in the stomach, they go into the duodenum and keep going and end up and they land in the jejunum.
Okay. So it's like a duodenum.
There's okay.
Say the term again.
Yeah, so a nasogastric tube is just a tube that goes up the nose and lands in the stomach, right? But that wouldn't solve a problem because you're just still putting food in the stomach, right? And that wouldn't help decrease the enzymes. However, if you have a tube that goes past the stomach, goes into the duodenum, and goes past the duodenum and lands in the jejunum or a J tube, right? Then the food is never in the duodenum, which is where, remember that opening is for the bile duct and everything. So when food is in the duodenum, that's where the pancreas senses it, right? Because there's that opening. If the food is never in the duodenum and it goes straight to the J tube, the pancreas will never sense the presence of food.
Okay, so as long as you can use a J tube to pass the duodenum so that the pancreas doesn't sense it, then the patient will be okay.
Yeah, it's just we can't keep a patient NPO forever, right? Because they need to eat, right? It's
yes,
like,
of course.
Yeah, so it's like, okay, well, if they have to be NPO for a long time, they might get a J tube. And that will just help bypass the stomach and bypass the duodenum so that it puts the food further down in the system, like in your body, so that it doesn't go into the duodenum where the pancreas is able to sense the presence of food and then release those enzymes. So if the food is deposited in the jejunum instead, the pancreas never has the opportunity to sense that presence of food and it won't produce more enzymes.
Okay.
Does that make sense?
Yeah.
Okay. So that's a potential option. The other option is, depending on the cause, you might do surgery. So like if you have a tumor, obviously you probably need to have surgery to get that removed, right? If you have really bad gallstones, you might need surgery to get those out. My dad had really bad gallstones, and he had to have surgery to get those removed. Sometimes they can pass on their own if they're small enough, but other times they just need to be surgically taken out. So those are a couple reasons why you might have to have surgery. Does that make sense? Any questions on that?
Yeah. I was flipping through some pages, but I was seeing NG tube, but I think it was under when you go to chronic.
Yeah. Any questions about any of those interventions? Fluids, pain management, calcium, that sort of thing.
I don't think so, because let me see. Everything made sense. You say pain management because they'll be in pain. Are you giving them NSAIDs since they have pancreas issue? Are you giving them something different?
No, you're gonna bring out like Dilaudid and morphine because those are like
Okay.
it's
Hardcore.
pretty intense pain. So yeah, you want to give them
Okay.
strong stuff.
Okay.
All right, let's go on to chronic. Chronic causes this. Okay, so this is kind of very similar to the renal system. So remember how you had acute kidney injury and chronic kidney disease?
Mm-hmm.
And remember how like acute happens kind of really fast and you have like an attack, a crisis. So same thing with like the pancreas. You have an acute crisis, like there's an acute blockage and like, you know, it has to be taken care of. Whereas with chronic pancreatitis, it's kind of like with chronic kidney disease where it's like a slow destruction of the organ over time. Remember, diabetes and hypertension were the #1 causes of chronic kidney disease that just kind of wears and tears over time. Remember that?
Okay.
So
You're reminding me.
yeah, with the pancreas, the #1 cause of chronic pancreatitis is alcohol. So drinking alcohol over time, like you're not gonna have acute pancreatitis from drinking one glass, you know. It takes years to kind of like slowly destroy that pancreas, right? Just same thing with, you know, chronic kidney disease. You're not gonna have chronic kidney disease from having diabetes for one day. Like it's a slow buildup of destruction and damage, right? So alcoholism is the #1 cause and risk factor. So that's why like some people tend to assume that people are alcoholics if they come in with chronic pancreatitis, but we can't assume that because there could be other causes, right? It could be an autoimmune problem. Sometimes autoimmune is just really weird. It's like your body just starts attacking itself. So sometimes your body decides, we don't like my pancreas. I'm going to attack my pancreas. And so it just like it's destroying your pancreas over time. And so it might look like this person has, you know, they've been drinking alcohol, but it's not from that. It's from just their autoimmune. Or it could be like, you know, an obstruction that isn't like completely blocked, but like partially blocked, and it just keeps getting worse and worse over time. So just various things. The main thing to remember is that alcohol is #1, but don't assume because patients will get offended if you assume that and they've never drank alcohol ever in their entire life. Same thing with like lung cancer. People assume that if you have lung cancer it's because you're a smoker, but that's not always the case. Some people get lung cancer for completely different reasons. So anyways, so signs and symptoms of chronic pancreatitis. Same, some are going to be similar, right? You're going to have abdominal pain because, you know, same reasons as acute. The chronic always has more signs and symptoms than the acute does, just because you have more time to develop them. Same thing with like the renal, like the chronic kidney disease had more symptoms than the acute kidney, just because it had more time to develop. So some of these symptoms that take more time is things like malnutrition. So chronic pancreatitis patients often come in malnourished. And why? Well, remember that the pancreas secretes these enzymes to help with the absorption of fats, carbs, and proteins. So if, you know, if the pancreas is losing the ability to make these enzymes, you're slowly going to not be able to absorb them. And so you're just going to be like getting more and more malnourished over time because your body can't absorb that fat. It can't absorb the proteins. Does that make sense?
Yeah.
So malnutrition is a big one. The other thing that's interesting is they will have fatty stools, meaning their poop is going to look different. It's going to be funny. They float in the toilet bowl and they kind of have a funny odor and they kind of look different colors. And the reason being is because again, your pancreas is not really able to produce the lipase like it used to. And the lipase is what breaks down and helps with the absorption of fat, right? So if you're eating like a fatty meal and you're not producing the lipase to absorb it, your body is just going to throw it out. You're just going to poop it all out, right? So the fat comes out in the poop and it just makes the stools float and kind of smell funny and look funny. So that's called steatorrhea or the fatty stools.
fatty too. Okay, I see the name. I was about to ask you, what does this mean?
Yeah, steatorrhea, Steatorrhea. So yeah, malnutrition, fatty stools, abdominal pain, diabetes. So here's where they actually do develop diabetes, because it's been so long, like for years and years and years, their pancreas is like losing the ability to create insulin, right? So now the pancreas is like permanently damaged, whereas with the acute pancreatitis, it's not permanently damaged, it's just in crisis, right? So if you fix it fast enough, you can save the pancreas and it will bounce back to normal. But over years and years and years, like of it not being addressed, the pancreas will just finally lose the ability to create insulin at all, right? Because those beta cells that produce the insulin will just be so damaged they can't work anymore. So now this person will be a functional diabetic because now they're insulin dependent, right? So they're just not able to produce insulin anymore. So these people will have to take insulin just like regular diabetics do. Does that make sense?
So they're insulin dependent.
So this might be helpful. So do you remember that there's two types of diabetes? There's diabetes type 1 and diabetes type 2.
Mm-hmm.
Diabetes type 1 is where you're born with your pancreas just not being able to produce insulin. For whatever reason, the beta cells just don't work, right? Or they barely work. Maybe they're able to work a tiny, tiny bit, but not good enough, or they just don't work at all, right? So that would be type 1 or insulin dependent, right? Because they require, you know, injections because their body can't do it on its own. Type 2 diabetes is different. They're normal people, you know, that functioning fine, but because of their diet, they're consuming like so much sugary foods all the time that their body is like constantly cranking out insulin to keep up because, you know, they're Twinkies and all the sugar, and so their blood sugar is always high, right? So their body is always having to produce insulin, and eventually they become insulin resistant, right? So insulin resistance is where like the body is like just unable to respond to insulin anymore because they're just constantly bombarded with it all the time, right? So it's not that they're having a hard time producing it, it's just that the body's not responding to it anymore. Does that make sense?
Yeah.
So with the chronic pancreatitis patient, their pancreas is being damaged to the point where their beta cells are just not able to produce insulin anymore. So they look more like a diabetic type 1 because it has to do with the cell's ability to produce insulin. They're not insulin resistant, right? Because they're not like, it's not because of lifestyle and diet, it's because their pancreas is just damaged.
Okay.
So they resemble a type 1 diabetic, if that makes sense.
They're now dependent fully.
Yeah. Does that make sense?
Yeah.
Okay. Okay, so pain, malnutrition, fatty stools, diabetes, ascites. Ascites is just like swelling and edema in the belly, and you can imagine that like they would just kind of have constant swelling and fluid just kind of on that belly because it's constantly being irritated, right? So there's that. Some treatments, interventions for these people, it's supportive, right? You can't fix it, you can't cure it because it's already been permanently damaged. You can't like fix it once it's dead. It's just like when you have a heart attack and that part of your muscle dies, like it's too late, you can't fix it, you know? Does that make sense?
Yeah.
So supportive care is just really just kind of managing their symptoms. So what you're focusing on is pain management and nutrition, making sure they're getting adequate nutrients just because their body's not making those amylase, lipase, all that stuff to be able to absorb it. So they might be on TPN, for example, and TPN just bypasses the GI system completely, right? It's just nutrients going straight into the bloodstream. They might get a J tube, the jejunostomy tube, right? They'll need insulin, you know, because they're not making it. They might even take some enzyme replacements. Like I think you can get like pill form or something of amylase, lipase, and all those different things. But yeah, there's no cure for it. It's just purely supportive. Okay. That's pretty much that for chronic. How do you feel? Any questions so far?
I don't think so so far. I just need to process it again by myself. You know, like once you are taught, you just like make sure you understand it. So I'll have to. But the way you're explaining it is very helpful.
That's good. Let me push pause on this recording real quick. There's someone in the waiting room and I want to see who they are.